Coming up to the stage, we have Dr. Naemat Sandhu. She's a transplant hepatologist at University Hospital. She'll be presenting another timely topic on alcohol associated with the disease.
Good morning, everyone. I'm Naemat Sandhu at University Hospitals, and we're going to transition over to the world of alcohol-related liver disease. I'm going to mix the bag up how alcohol impacts certain spectrums of steatotic liver disease spectrum. So we're going to start off with Met-ALD and then transition over to the field of ALD. So in the liver meeting, there were about 300 and more abstracts and oral presentations, right, which were covering the breadth of steatotic liver disease spectrum on how the alcohol and metabolic factors really contribute to the spectrum of disorder in liver diseases. The other major themes were that how do we improve our alcohol use measurement technologies and interpretation in real life. Transplantation was a big topic, right, in alcohol liver disease as well as alcoholic hepatitis, so we'll see some data about that. And then interventions that we're implementing to treat alcohol use and what kind of a job are we doing as a community for our patients with alcohol liver disease. So starting with a few abstracts from Met-ALD, or the spectrum of steatotic liver disease with alcohol. So this first study was a 10-year risk estimate from nationwide Danish cohort, which looked at whether there was synergism between alcohol and cardiometabolic risks in the development of cirrhosis. So in Denmark, they have a tax-funded universal healthcare system, so there's nationwide registries for diagnosis, prescriptions, and deaths. They basically looked at people who enrolled and provided a population-based survey. So there were about 350,000 adults without cirrhosis to begin with who filled out a survey, and so there was retrospective analysis from the time of 2010 to 2017. They had a 3.3 million person-year follow-up, and the study concluded in 2022. At the end of the study, the incidence of development of cirrhosis in this cohort was about 1,211 patients. And this kind of graph really highlights nicely how alcohol and BMI interplay with the risk of development of cirrhosis. So on the y-axis, you have higher rates of hazard ratios of developing incidence of cirrhosis. And from the x-axis, on the top is how much alcohol those groups were drinking. So you start with the least amount of alcohol use, 1 to 14 drinks, and on the extreme right is more than 42 drinks in a week. And at the bottom, within each subgroup of alcohol use, there's increasing strata of BMI. So what was really nice to see, and interesting to see, not nice, but interesting to see, was that as the alcohol consumption grew, the risk of incidence of cirrhosis grew, right? But the interplay between BMI and alcohol seemed to level off when we got into the higher groups of alcohol use. So the BMI correlation and synergism kind of cut off when the alcohol consumption was up to 28 drinks per week. So our takeaway from here, from this study, was that contribution of alcohol after 28 drinks per week superseded pretty much all other cardiometabolic risks that were looked into in the development of cirrhosis. And so the effect of BMI, needs to be considered, and this was quite a bit of discussion in the room when this abstract was presented, whether we need optimization of Met-ALD parameters moving forward. So I think as we learn more and more about this disease process and how these factors interplay with each other, we'll probably narrow down our definitions on how we understand Met-ALD. So this next study was increased alcohol use after bariatric surgery, right? So a really kind of key group of patients that we all see in our clinical practice, and how alcohol use predicted the fibrosis progression in MASLD patients. So this was a study population of 455 patients, biopsy-proven MASLD, and majority of them underwent sleeve gastrectomy, but a good chunk also underwent root gastric bypass. And they were followed for a median of 7.5 years. Now, the study kind of basically looked at FIB4 as their marker for fibrosis progression. So obviously that had some limitations, but 18% of this cohort had an increase in their FIB4, which was interesting to see. And with the multivariable analysis, any change in audit C-score, right, for alcohol use bumped up that hazard risk. FIB4 is dependent on your age, so as age increased in this cohort, the risk went up. But losing weight after bariatric surgery, again, reinforced that, the risk of fibrosis progression does go down if people lose weight after surgery. And then an important point that the study highlighted was that, there is a discrepancy between the risk for women versus men. So any 1 point increase in the audit C-score for alcohol use after bariatric surgery for women was conferring much higher risk at every kind of uptick of that audit C-score. And for men, that risk didn't really take up until that audit C-score changed by 3 points. So the authors concluded that the increase in audit C after bariatric surgery is associated with liver fibrosis progression. Longitudinal screening should be performed quite diligently for these populations and probably for a very, very long time. And it just kind of opens the kind of conversation for interacting with patients in our clinics, right? When we see these patients, I think, not only in the bariatric kind of clinic, but in our clinics in hepatology and GI, that we should be more proactive about alcohol use screening and the risk of fibrosis progression for them. Right, so moving on to incretin-based therapies and how do they affect alcohol use after bariatric surgery. So again, the same kind of group of patients, that we know are at high risk of fibrosis progression after alcohol use after surgery, can we help them in minimizing that risk when they're receiving incretin-based therapies. There's already data out there that suggests that there is improvement in the craving for alcohol use and the risk of alcohol use if incretin therapies are being used for weight loss. And so this was a Trinetics database study, a retrospective study which looked at about 15,000 patients from 2020 to 2024. And the two groups were incretin-based, where patients either got semaglutide, liraglutide, or tirzepatide, and the non-incretin-based group received phentermine, orlistat, and naltrexone. So what the study kind of authors did, after bariatric surgery, when someone needed weight loss therapies because either they had regain of weight or lack of weight loss, they then tracked what was the onset of development of alcohol use disorder, or when they were prescribed alcohol use disorder medications as a treatment for the same. So they used ICD codes to ICD diagnosis codes to pick that up. The median follow-up for this study was about 2 years. And so this first graph shows the onset of AV. It doesn't project really well, unfortunately, but essentially with the incretin-based therapy, the incidence was much lower. So we see that pink line on the screen, and there's a blue line just underneath it. So the incidence of development of AUD in the incretin-based therapy was much lower, with a hazard risk reduction of 55%. The same was the case for when they needed medications prescribed for that alcohol use disorder. So there was a 41% hazard reduction for these patients. So again, just bringing up another way that we can maybe expand usage of incretin-based therapies, right, to tackle another risk factor that these patients face after bariatric surgery. I think one key thing with this study was that their median period from when bariatric surgery and the anti-obesity medication was prescribed was 3 years. And that's the highest period when these patients are at risk for developing alcohol use and alcohol use disorder. All right, so another study that C's et al.'s group kind of focused on was how does binge drinking and metabolic conditions increase risk of premature mortality in the steatotic liver disease spectrum. So again, an NHANES database study that they kind of used to assess the prevalence of the spectrum of steatotic liver disease in the US from 2017 to 2023. A key thing that they did in this study was that they corrected for suspected alcohol underreporting. I think we're all kind of quite aware in our clinical practices that alcohol kind of use reporting is quite fraught with variation, right? And so they applied sex and frequency specific correction factors for self-reported alcohol use and scaled it to match the US per capita ethanol consumption. So in the top right graph, you see that in the red bar is the data of the prevalence without adjustment for alcohol use. So for MASL, the prevalence was about 35%. For ALD, it was 1.28%. For MET-ALD, it was 2.27%. And then when they adjusted it for alcohol use correction, right, ALD kind of prevalence went up to 4.9, MET-ALD prevalence went up to 3.9, and then MASL dropped a little bit. And then interestingly, premature mortality rates were the highest for alcohol liver disease group, and it kind of fell through the spectrum of steatotic liver disease when compared to each other. The key drivers of premature mortality for MET-ALD and alcohol is binge drinking. the population attributable risk was as high as 71 to 92%. So I think we really need to kind of hone onto that fact that it's not only regular alcohol use, but also binge alcohol use that drives premature mortality for these patients. And then diabetes was the highest risk for the MASLD group. These two kind of graphs basically walk us through, when increased alcohol use is happening in the MASLD spectrum. So from the left-hand side of the x-axis is MASLD patients who abstain from alcohol, and on the right-hand side is alcohol liver disease. And on the left side, we're seeing the interplay of the presence of diabetes and hypertension together in the spectrum. And on the right-hand side, it's binge drinking with diabetes. And so the darkest green bar in both groups shows that diabetes and hypertension on the left confer the highest risk in all the subgroups. And on the right-hand side, it's binge drinking with diabetes in all subgroups that's rising their premature mortality. So again, just interplay on all these factors, which I think we'll come to learn more about as kind of we gather more data. So in this study, alcohol correction kind of reconciled, the prevalence and the mortality paradox in the spectrum of patients. Majority of alcohol liver disease patients have metabolic dysfunction. 95% of them in this study did. And binge drinking amplifies their risk, unfortunately, in the case of Met-ALD and ALD. So using PET as a biomarker, we're all kind of incorporating this hopefully in our clinical practices to screen for alcohol use, hopefully across the spectrum of steatotic liver disease. But there's still a gap in the knowledge of the true prevalence of alcohol use disorder in SLD as a spectrum, right? So Rohit Lumba and his group kind of used this database from the San Diego liver study, and they wanted to kind of explore what the prevalence was in that subgroup. So the overall prevalence in their San Diego liver study database was 5% for alcohol use disorder. And how they kind of diagnose alcohol or gather that data is through clinical diagnoses that were documented. So that was use of audit Cs, use of the DSM-5 criteria, as well as PET. And so the prevalence of alcohol use disorder, not surprisingly, was highest for patients who are labeled as ALD, so 50%. 40% in Met-ALD, and quite low at 3.7% in MASLD. The nice thing to see in the study was that PET had a really good accuracy with high AUROC, and when they compared it to other non-invasive markers such as AST-ALT ratio, MCV, GGT, it kind of outperformed those markers to pick up on patients with high-risk alcohol use behaviors. One kind of cutoff that the study proposed was that in their analysis, they noticed that the cutoff of 43 had a really high negative predictive value, good specificity, not great sensitivity, but decent sensitivity. And so they proposed that maybe a cutoff of 43 in steatotic liver disease should raise conversations around the concern of alcohol use disorder in our patients. So again, I think my takeaway from this study is that using PET as an objective biomarker, opening that kind of forum with your patients to discuss their alcohol use, and not necessarily providing them with a label for alcohol use disorder, using a specific cut point, but just using that as a guidance to have conversations about intervening to help them with their alcohol use. All right, so now we're going to transition to alcohol use disorder solely. We're going to move away from Met-ALD and MASLD and how that interplays with alcohol. And so long-term outcomes after hospitalization were reported by the single center study for acute severe alcohol-related hepatitis. So this study had about 154 patients who were admitted anytime between 2012 to 2022. They all underwent liver biopsy and H3PG measurements. Now, of the initial 154 patients, about 13 died or were discharged to hospice in that indexed hospitalization. 6% patients underwent transplant, and 18% were lost to follow-up. So that kind of boiled the study group down to 103 patients who were followed for a median time of 1.8 years. And so the baseline characteristics of these patients were that they had very high MELD scores, so 27, high Maddrey discriminant functions. Not surprisingly, they had high H3PG measurements. But I think a key point here is that more than half of the subgroup had cirrhosis on the initial biopsy. And non-cirrhotic patients were only 16% of the subgroup. when we break down the analysis based on their fibrosis staging at the time of their initial presentation, and virtually all these patients are similar clinically, right? So they are the same age, the same baseline MELD in the mid-20s to high 20s. Most of them had ascites, the same degree of variceal bleeding risk, and hepatic encephalopathy. So just goes to kind of show that clinically it's really hard to distinguish who's a cirrhotic with alcoholic hepatitis versus who's purely alcoholic hepatitis without fibrosis. What did differ is that the baseline H3PG measurement was higher in the cirrhotic subgroup than those who were not fibrotic or with little fibrosis. And so the outcomes with the study, they looked at patients who died during follow-up, which was about 46, and those who were alive at the end of follow-up. And they were quite similar with regards to age, sex, the H3PG measurements, and how many patients had biopsy-proven cirrhosis to begin with. Where they differed is which patient kind of attained abstinence early on, right? So patients who died during follow-up, about 44% abstinence rates versus 84% abstinence rates in the other group. This was echoed again in the recompensation data. So they looked at patients who recompensated, which was only 19 of the total of 103 patients. So really low incident rates of achieving recompensation clinically. But 90% of patients achieved abstinence early on as compared to 60% of patients in the no recompensation database. And so, again, it just kind of highlights the complexity of this conundrum of alcoholic hepatitis. It's not an easy disease to kind of treat, manage, and I think it just kind of hammers the point that recompensation is still quite a rare phenomenon. And so this was kind of nice data to see. So we're always kind of looking out for new scores on how do we predict the risk of return to drinking, right? And so this study looked at essentially a novel score which was called the Metabolic score, and they specifically targeted patients who had alcohol-associated hepatitis. So this was a multi-center observational study using the ALCAP-NET database, and they prospectively followed patients for about 200 days. The primary outcome was to see if patients returned to drinking using a feedback kind of gold standard of timeline follow-back, and they split the cohort into 70% for model development and 30% for validation. They looked at 347 patients, and about 28% had returned to drinking. And the Metabolic score basically comprised of a couple of different variables. So MELD, ethnicity, race, age, gender, and education. And they compared it to another risk factor score called high-risk alcohol relapse score, which uses subjective and objective variables like duration of heavy drinking, quantity of daily drinking, and previous alcohol treatment. And in comparison to this score, Mirage kind of had better sensitivity of 0.71 as compared to 0.38. The AURC was 0.69, so much superior than the 0.54 of the previous score. And so this is just an example of potential kind of scoring tools that people are exploring to predict the return to drinking after an episode of alcoholic hepatitis. My takeaway here is cautious interpretation of these scores which use demographic factors, right? So if you're incorporating ethnicity and etc., there might be bias that might be coming through, whether that's passive or inadvertent bias. And so again, not ready for clinical practice use, but just something kind of, stir conversation. All right, so this really kind of important kind of data set from the Accelerate Alcoholic Hepatitis Study reported 10-year post-transplant outcomes for the patients who received, early liver transplants for severe alcohol-associated hepatitis. So this study, has had 9 U.S. liver transplant centers who enrolled patients who underwent early liver transplants for severe alcoholic hepatitis between 2007 and 2024. And the total number of patients enrolled here were 450. This was retrospective analysis, and all the patients in the subgroup who underwent transplant had less than 6 months of alcohol abstinence, right? So to begin with, their baseline characteristics essentially highlighted that there wasn't a long period of sobriety. Most patients, the median interval from stopping alcohol use to getting a liver transplant was under 2 months, 51 days. very high, use of alcohol, which was not surprising given the subgroup that we're dealing with. But another key factor here was that about 16% of these patients had prior decompensation of liver disease with return to alcohol use, who then presented with alcoholic hepatitis and got transplanted, right? So a lot of these patients had high-risk psychosocial characteristics to begin with. In the bottom half, this is the Kaplan-Meier curve of, overall the kind of post-liver transplant survival. And at 1 year for this group, the survival is 94%. At 5 years, it's 83%. And at 10 years, it's 70%. So these survival kind of, numbers are actually at par or even might exceed some of our conventional reasons for undergoing liver transplant, right? So for MASL, for HCC, for alcohol cirrhosis. So this group performed quite well with regards to their survival. Now, the data that we're interested in is how many people, return to drinking, right? So on the left-hand side, in the blue, depicts any use of alcohol. So that could be one drink, that could be regular use, that could be binge. And so at 10 years, about 53.7% of these patients had some degree of alcohol use reported. And then harmful alcohol use was about 34.6% at 10 years. When we look at the survival curves for these patients, at 10 years without alcohol use, the survival was 85%. And that dropped dramatically if there was harmful alcohol use, and the survival was only 38% at 10 years. Of all the mortality that was reported in this subgroup, 27% were directly just related to alcohol use itself. So a third of patients who passed away was a direct kind of consequence of that alcohol. And then there was multivariable model kind of estimation to see what are the risk factors for post-liver transplant mortality, right? So prior history of liver decompensation with history of alcohol use, having another episode of alcohol, that was certainly a risk factor. And then any alcohol use or harmful alcohol use post-transplant resulted in increased liver transplant mortality risk. The multivariable model prediction for harmful alcohol use after liver transplant identified two risk factors that were important. One, that if someone's had several attempts for failed rehabs for alcohol use prior to liver transplant, those were high risk. And then patients who presented with grade 3 or grade 4 encephalopathy at the time of transplant were at high risk for harmful alcohol use. Likely highlighting the fact that we might not have an opportunity to evaluate those patients' psychosocial situation really in depth if they're having significant encephalopathy at the time of their presentation. All right, so moving on to PET again, but looking at some real world data, right? So not only patients who live with liver disease, but in general, what are patterns out and about in the world with regards to demographics and their clinical correlates. So this was a study that looked at 4,892 patients from Mass General and Brigham between the years of 2022 and 2024. And the incidence, the prevalence of positive PET was about 40% in this cohort. In the bottom left, we have the PET kind of results in this cohort, and it's not a bell-shaped curve. Like it's not like a nice-looking bell-shaped curve that we're used to, but it's skewed to the left side, which is the lower spectrum of PET results. However, the median PET was 251, so still quite high. On the right-hand side, on the top, you have how PET stratified with regards to age. And so patients who were younger, less than 55 years of age, had higher PET values as compared to patients who were more than 55 years of age. And there were no differences between men and women when it came to analysis in this group. And the next slide basically highlighted, I think, what a lot of us see in clinical practice, that the correlation between self-reporting of alcohol use and their PET levels are skewed. So on the left side, with this plot, on the y-axis, there's increasing reports of the amount of drinks someone's reporting, and on the x-axis is PET. And those two levels don't correlate. So someone could be reporting that they're drinking 50 drinks a week, and their PET could be more than 1,000. And at the same level of PET, someone could be reporting drinks of about 20 to 30 drinks a week. So this just kind of highlighted that, yeah, there remains a discrepancy in self-reporting of alcohol use And I think we need to just do a better job of destigmatizing conversations around alcohol use. All right, so talking about alcohol use and using PETs, moving on to now treatment for alcohol use. So this study looked at naltrexone and acamprosate, an alcohol use disorder with cirrhosis, and basically how mortality and morbidity is affected by use of AUD in patients with cirrhosis. And the takeaway from this study was that naltrexone seemed to outperform acamprosate with a survival probability of 64% as compared to 58% in this cohort. Now again, this was a TriNetX database study which relied on ICD codes, so there was no reporting of true PET levels or alcohol use levels with regards to true objective parameters. But it was nice to see that there was lower all-cause mortality with naltrexone, lower risk of hepatic encephalopathy, lower AKI trends over 5 years. And I'm going to end with this study, which was a phase 2 study that looked at rifaximin plasma exchange and GCCF in alcoholic hepatitis. So the authors of this study basically looked at patients who presented with alcoholic hepatitis and who presented with just liver failure, meaning jaundice, and coagulation failure. They excluded patients who had multi-organ failure from this cohort, so again, alcoholic hepatitis patients who were not severely ill. And they randomized them to either the control arm of standard medical therapy versus standard medical therapy and the combination of the treatment arm. All of these patients had already received a week of steroids as a trial for treatment for ALK-HEP, and they had failed that, and so this was basically supportive care versus the treatment arm that was multimodal kind of pathway of attacking ALK-HEP. And they did show that there was a improved survival probability in the treatment arm. That was evident at 30 days, 60 days, and 90 days. So at 30 days, the survival probability for the treatment arm was 94% as compared to 76.5% for the standard of care arm. And that survival benefit persisted at 85.7% to 60% at 90 days. And then there were lower risk of infection rates as well for the treatment arm, reduction in all of these scores that we looked for, MEL score, Cliff C score, Maddrey discriminant function scores. So just kind of interesting data to see that, since we don't have a lot of treatments for alcoholic hepatitis, unfortunately, other than transplant, that there might still be, pathways to target to help these patients. I'm going to kind of end with this slide because there were a lot more abstracts that had really interesting information come through. Not only how PET biomarkers are kind of, interacting with other kind of alcohol use scores that we use in our clinical practice. How are the rates of prescriptions of alcohol use therapies after transplantation, which is a field, again, I think that we have a lot of work to do in. And the multi-center kind of Bellino study, which also focused on rates of recompensation with abstinence. Thank you.